person who reacts to peanut. And that reflected our clinical experience at the time, and that was why we did the study, as we were seeing a lot of patients having severe reactions to cashew nut. And so that is a particularly potent allergen in our experience. So the other patient question is, what can I do then? What can I do to help myself? Well, obviously good patient education is paramount. Read food labels and ask in restaurants. And unfortunately, even though people do all this all the time, they do it well, they're relying on the restaurant staff to do their job well, and they often don't. So do carry your emergency medicine wherever you go. Make sure it's with you on a night out. Do control your allergic rhinitis and your asthma properly. And this is just to explain that reactions can happen anywhere, and these are the circumstances of accidental reactions at home, of course, school, at a party, and the sorts of people who provided the allergic food. And we've seen some rather odd ones like on an aeroplane, or Santa Claus in Santa's grotto, or a scoutmaster. So it can happen anywhere. These children have to be careful wherever they go. However, it's a balancing act, because we want these patients to feel safe and competent to manage their allergy, but not feel overwhelmed that there's a life-threatening problem. So it's all about balance. Can I eat other types of nuts? Well, we've shown that older children, shown by the black bars, usually are sensitized to multiple types of nuts, and this is reflected also in clinical allergy. So this is testing, and this is clinical allergy. So when the children get to their second decade and they present to us, they're often allergic to multiple types of nuts. So it's important to try and define that for them. And this is that one circumstance where I would say, please do test for other foods. And I would just do this panel if I was faced with a peanut allergic patient. But what I wouldn't do is test nut types which they eat and tolerate. So for this case, it's almond. It's not done because this child eats almond without a problem. If it's slightly positive, we don't want to know. They're eating it, they're fine. So we won't change their management. But what we find out, as this case, is if we follow this child up over the years, the skin tests settle down. We often find that there's a sort of a shotgun effect. All of them are positive at the beginning. But if you follow children up, you'll find that they settle down and often they'll become negative. And you'll end up, as this child in our follow-up this year, with a bit of a gap for COVID, that we've got skin tests negative to Brazil nut, hazelnut and walnut, but strongly positive. And you see these patterns emerging over time. So it's quite important to follow patients up to allow this to happen, because then patients will have the choice to introduce those nut types. So for us, we've allowed them to introduce nuts where they've been skin tests negative on 2 occasions, just to exclude a rogue skin test. And then we perform gradual reintroduction, starting off with a tiny amount, then a crumb, and then a bit of a spoon. And we've got this written in a pro forma for the patients, and they'll do this at home for those negative tests. Now we use skin prick tests because they do have a high negative predictive value, but I wouldn't attempt this with serum IgE, I'm afraid, if you're going to try reintroduction, because the false negative rate on serum IgE is about 20%. Can I go on an aeroplane? We get this a lot. Presumably you guys do too. Yes, but it's all very sensible. The bottom one is the thing they're asking about, really. They're worried that they're allergic to airborne contamination. In reality, this is not a problem. What happens in those cases is that someone's touched something that someone else has had peanut on, they've rubbed their eyes, they get some eyelid swelling, and they get a bit panicky and breathless because of an aeroplane. Someone says, is there a doctor on the plane? And then a psychiatrist stands up and says, yes, I'm the doctor, and goes to see the child, and everyone panics. So it's all a bit made up, this business about really bad reactions on planes. I think you can reassure everyone that they're not going to have an airborne reaction on planes, but do take some sensible precautions, because we've all found peanuts stuffed down the back of the seat. Will it go away? It's very unlikely, that's exactly what I say. And you'll all be aware the literature says about 20%. But in my experience, it hardly ever happens. And if it does, it's really in this group. Mild inert reaction, allergic to one nut type, only a few comorbidities. And what treatments are available? Well, Palforzia is the oral immunotherapy treatment. It's the the only one that has a license, and that's only in the US and Europe, and not in GCC or MENA. It prescribes daily updosing and long-term maintenance, and has about 60% efficacy rate, but it's got a lot of trouble associated with it. 20% of patients drop out during the first year. 14% in the US trial needed to use adrenaline. And remember, these are patients, if they've just avoided peanuts for that whole year, would be very unlikely to even have had an allergic reaction to peanut, let alone use adrenaline. So patients have to make a big adjustment to this. So I'd just like to put in another shout for our BSACI guidelines. These are really excellent. And some patient support materials. The EpiPen Injects websites, I would always direct patients to these. They're very, very useful, with lots and lots of different facilities on there. And I think the Jext is now available here. And the Jext app is really useful. It will talk patients through how to use their adrenaline auto-injector. And on another section, it has translation phrases that your phone will speak if you go to a country where you don't speak the language. 2 minutes. So I'm just going to do a couple of cases. In fact, I'm just going to do one because one of my cases was is a duplicate of something that came before. So this is my case. So it's a 22-year-old month, and this is just to demonstrate that the rules that I described about interval between eating the food and reacting can be broken in certain circumstances. So this is a child who vomited profusely several hours after eating food on 2 occasions. It looks like gastroenteritis. On each occasion, the child's eaten salmon. Has anyone seen this before? Yeah, exactly. So this is exactly. So this is something we see in infants and toddlers, and mimics gastroenteritis. It can be severe, classically described as fish or cow's milk protein, and it resolves. So by the time they reach toddlerhood, usually they are better. In almost all cases, it's very rare that it persists. And you should provide a treatment plan for accidental reactions, because they can present to emergency departments as shocked septic children or gastroenteritis. So all the differential diagnoses have to be considered if they go to the ED. And finally, I will do this one because it's quite fun. A case of a 7-year-old male who's known to have nut allergy, but he had an unusual reaction. He had lunch, that was fine. Then he ate dinner, it was absolutely fine. Then he had football coaching, and the coach called parents at 5:30 in the evening and let you know what he said. Your child's coughing, got rhinitis, is unwell. The mother, who's an ED physician, picked him up. He had generalised urticaria, difficulty breathing, drooling and wheezing, and he had quite severe anaphylaxis. And I think you've all worked out what this is. This is food-dependent exercise-induced anaphylaxis. He's got a positive wheat IgE, and this is very typical. So the other issue here is this will delay the onset of the symptoms, depending on when you exercise. But if you exercise 2 hours after you eat the food, then you'll have the symptoms. It's often due to wheat and shellfish, and as mentioned previously, lipid transfer protein in adults. It's very severe, and I offer this as a contrast to the case that was shown before, where I think the patient was only walking around the shopping mall with very mild exercise, which can happen, but this was quite vigorous exercise, which is more typical of what we see in children. So this is my last slide to say thank you, and I will also put in a plug for all of our great guidelines written by the BSACI, and I had the honour of chairing the BSACI Standards of Care Committee for 8 years. I've only just given that post up, and during that time I supervised writing all of these guidelines, who were written by really great experts, both in the UK and abroad, and I really recommend that you have a look at them if you have any questions. So, thank you very much.
Thank you very much. We're going to take questions at the end because of time, if that's all right. It's an excellent talk. Our next speaker, she's here, Dr. Carla Irani. I haven't met her before, but I'll just do an introduction. She's an allergist and asthma specialist and an immunologist as well. She's American board certified. She studied, lectured, researched and treated asthma allergies, immunology over the last 15 years. And she currently works in Lebanon. She treats adults mainly, but also children. It's a pleasure to have you here.
Thank you for your kind introduction. I would like to thank the organizers, Dr. Russell, for the invitation. I will talk mainly about chronic urticaria in the pediatric population, which is a little bit challenging because we know that acute urticaria is much more common. So by definition, it's important to define acute versus chronic, where acute is less than 6 weeks and chronic is more than 6 weeks duration. And the definition about urticaria is very important because many times people or even the parents will mix up this shape of rash. So these are maculopapular lesions, itchy, and usually disappearing without leaving scars, except when we talk about urticaria vasculitis. And when we talk urticaria, we can also talk about angioedema, which is the same, but it is the edema of the dermis. When we talk chronic urticaria, we have to talk about physical urticarias, and one of the most common is symptomatic dermographism, which you see here on the picture, where you can do it in the clinic, or even the parents or the adolescent or child will tell you, every time I scratch, I have these lesions that disappear very quickly. They are itchy and very well controlled with antihistamines. Cholinergic urticaria are very common in adolescents, but also in children, and this is the typical pencil eraser size of urticaria that appear after exercise, after emotion, or any cholinergic trigger, also disappearing without leaving scars very quickly. The cholinergic urticaria actually can be triggered by hot bath or high temperature and even by metacolon skin test. Cold-induced urticaria is common even in our part of the world because we tend to think that this is not common, but we see this difference between heat and cold. So, for example, a child jumping in the swimming pool, in a cold temperature swimming pool, you can see the cold-induced urticaria even if we live in a warm country. And also we can make a diagnosis with the ice cube test in the clinic. Therapeutic options are mainly antihistamines. Second generation antihistamines are the gold standard treatment for chronic urticaria and all physical urticarias. I will show you some guidelines. Very important to think about corticosteroids as only a very short treatment. We see many times, I don't know if this is a common practice in your part of the world, but at least where I live, unfortunately, we still see patients being treated with intramuscular steroids, which is a very bad practice for chronic urticaria. So whenever we are prescribing corticosteroids, we have to be very careful and do it only for a short period of time. As I mentioned, second generation antihistamines are the gold standard. These have been shown to have many anti-inflammatory properties and not only itching or anti-symptomatic treatment. And that's why it is very important to do the main treatment as second generation antihistamines and not first generation. So these are the guidelines actually about chronic urticaria. I will show you some particular data in children, but also this is a general scheme where you start with the second generation antihistamine, single dose, and if you don't have a response by 2 weeks, you can go up to 2 times per day and even up to 4 times again of non-sedating antihistamine. If that fails, the second option would be to give anti-leukotriene antagonist, and if that fails, we can add anti-IgE or cyclosporin. I will show you also some data keeping in mind the side effects of cyclosporin in adults, but also important in children. So chronic urticaria is actually an opposite of acute urticaria. We don't have any symptom. We may have some, we don't have any reason or etiology. We may have some triggering factors that I will talk about, but also we can have what we call chronic spontaneous urticaria, which can be autoimmune. Angioedema, as I mentioned, is very important to ask about whenever you see a patient with chronic urticaria, and to keep in mind that hereditary angioedema is present only when we do not have urticaria. So the only time we order C1 esterase inhibitor to diagnose hereditary angioedema is when we do not have urticaria. So urticaria in children, particularly, of course, with acute urticaria, one of the most common etiology would be infections. Any cold, upper respiratory infection, any viral disease. Foods, we heard a lot within the last 2 days, very interesting talks about food, so I will not talk too much about it. But it is important that we have this misconception about food dyes causing urticaria. I think we have to be careful because this is a really very rare etiology. Medications, of course, drug allergy is another cause. We know penicillin, antibiotics, but we tend to forget about non-steroidal anti-inflammatories or aspirin. Non-steroidal anti-inflammatories being a major trigger of either precipitating an acute urticaria or worsening a case of chronic urticaria, so this has to be discussed with the parents. Environment, of course, if the patient has sensitization to pets and they have a cat or dog at home, this may be a common cause of chronic urticaria. Again, a misconception about detergents, fabric softeners, etc., shampoos, these mainly cause contact dermatitis and not acute or chronic urticaria. So chronic urticaria in children, it's true that we have some gaps about the knowledge, but we have new publication about chronic spontaneous urticaria in children. Most cases are acute and self-limiting, but chronic urticaria can be present in the pediatric population when it exceeds 6 weeks. The prevalence is low, is 0.1 to 0.3%, but can go up to 1.2%, 1.2% being the same percentage or prevalence in the adult population. Most pediatric cases of chronic urticaria are reported as spontaneous, so no particular etiology. But of course, as in adults, pediatric chronic idiopathic or spontaneous urticaria has a major impact on the quality of life and sometimes has a low resolution rate, about 10% per year. This is from an article from the Journal of Allergy Clinical Immunology, just showing you, I will not bore you with the details, but showing you that we do have meta-analysis and studies of chronic urticaria in the pediatric population, in particular for treatment, because of course we cannot extrapolate the data from adults to pediatrics, but we have studies showing the efficacy, for example, of second generation, in particular bilastine, desloratadine, rupatadine, etc. But we also have studies showing the efficacy of omalizumab, anti-IgE, in chronic urticaria in pediatrics, and it's shown in this article showing multiple randomized controlled trials showing the efficacy and also the indication of omalizumab in these difficult to treat patients. So the agents currently authorized for children aged 2 to 11 years include the second generation antihistamine, desloratadine, cetirizine, levocetirizine, loratadine, rupatadine. Bilastine is the new antihistamine that is also very effective, rapid onset, and has a prolonged duration of action.